So our last speaker for this first session is Dr. Rohit Joshi from India. He's going to talk on UROLIFT in benign prostatic hyperplasia as an emerging option. Over to you, sir.
Good morning, warm greetings on behalf of USI. Before my clock starts, Kalana, where are you? Reading your messages on WhatsApp. It reminded me of famous dialogue from Check the India. ये 6 minute तुमसे कोई नहीं छीन सकता. And I think that 6 minutes which we have will start once I have my presentation. Today I'm supposed to give you a brief about UROLIFT, which is an emerging option for BPH. But before that, let me acknowledge the kind invitation and an opportunity to speak in front of this august audience. Let me extend my sincere gratitude to my friend Dr. Madhusudan Agrawal, sir. Dr. Rajiv TP is not here, Dr. Pavan, and Dr. Kalana, if he is there. Thank you so much, office bearers of South and Slavs, for granting us opportunity. This is going to take a lot of time. Is that so? Anyway, it takes some time. Till that time, let me give you a background of why we are discussing UROLIFT. See, we all have been doing TURPs and HOLEPs for years together, and both of them are, without any doubt, gold standard procedures as far as we are treating the LUTS component. But time has come that we think beyond LUTS when we talk about BPH. Now, even in many malignant conditions, our focus is more about the quality of life. So why not for the benign condition like BPH? So our focus has to be not just for the sole motive of curing someone's LUTS arising out of his BPH, but more focus should be on the quality of life, which involves his quality of recovery, his return to normal activities, his maintenance of his antegrade ejaculation, sexual function, and all these parameters, they add a lot to the quality of life for a patient who is having BPH. The problem is not the patient, the problem is we as the urologists, because whenever we see a patient who comes with an LUTS because of BPH, our entire focus is on just to cure him of his LUTS. And we hardly bother to ask him about other parameters of BPH. We hardly bother about asking him whether he is interested in maintaining his antegrade ejaculation or not, whether he is interested in maintaining his sexual function or not. And that's how we need to train our own mind to find the other components of BPH and then be able to offer the patient what is new and what is there, which can have preservation of all this kind of, other components of BPH. And that's how the minimal invasive surgical therapeutic options, which we call as MISTs, came into the vogue. And for last 2-3 years, we have seen a significant paradigm shift in adoption of these technologies by both the patient as well as the urologist. And today, I'm going to talk about, finally, the UROLIFT. Can we have the slideshow now? I'm sorry for this 2 minutes impromptu talk. Moving further, let me not waste any more time. So, I do believe TURP and HOLEP is in gold standard, but it's gold standard only when we focus on the LUTS component. As I said, when we understand that there are so many different components, that's where we see that there is a space for MISTs. And that space is as much as what space in this slide. I do see 1 or 2 out of those 10 or 20 prospective surgical patients where I can offer UROLIFT. There are 2 kinds of MIST. We are focusing on UROLIFT today. What is UROLIFT? Very briefly and very precisely, we can say it's a mechanical solution for a mechanical problem, which is the most logical one. Now, there are several fragments under which next 5 minutes I'll be taking you through the brief about UROLIFT. Yes, it has been there for last a decade or so. First, it was described in Australia, then in US, UK, Europe, and it came to India last year. We are almost close to 1 year. We conducted more than 100 cases in one year. The basic concept in UROLIFT is to create an anterior channel. We are not going to do anything in the posterior 2/3 compartment because we know there are neurovascular bundles over there. So we do only treat the anterior 1/3 compartment. There are 2 kinds of action. One is a mechanical. Because of the tenting, the urethra becomes wide. And then there is a delayed kind of histological remodeling happening, apoptosis happening, so that even if the prostate keeps growing, the curvature is maintained same. So there is a durable results of all these things. Now, these are standard indication. Any man who is bothersome, more than 50 years of age, whose Qmax is less than 15, who is keeping large PVR, prostate volume, say about 80 ml or 100 ml, that can be taken for UROLIFT. There are certain contraindications. There are absolute contraindications like active UTI, presence of any urethral stricture, any suspicion of carcinoma prostate, or if the prostate volume is more than 80 or 100. These are some relative contraindications. If patient is having AUR, his results are not as good. and with sizable intravesical extension with a median lobe, these are not good patients for UROLIFT. This is the armamentarium. Left is the routine cystoscopy, and the right is the UROLIFT assembly. The scope which we use in UROLIFT assembly is slender, 2.9 mm. It's an extra long. That is to accommodate the width of this particular implant. And have a look at the device. The device has several different things. It has got a shark lock, scope lock. It has got a needle trigger, retraction lever, and urethral end piece. This is same like a GI stapler. We need to get acquainted using this. And these are the implant subcomponents. There is a urethral component, which is 8 millimeter. There is a prosthetic component, which is capsular tape, which is made up of nitinol. And there is a suture polyethylene, which maintains the tension between these two implants. That's how the implant works. The procedure is standard. We do cystoscopy, assess prosthetic urethral length to ascertain how many number of implants we'll require, and the protrusion of lobes. That judges how much degree of compression we need to apply. This is a small video. This is an animation video. For the sake of time, I'm running both of them parallelly, and we can actually achieve whatever we could see in this animated video. What we are doing is we are compressing the right lateral lobe of the prostate of patients and applied the first implant. Then we did the same for the left lobe. And since the urethral length was long, so we had to apply 2 sets of implant in the animation part. However, in the actual clinical video, the prosthetic urethral length was 3 centimeters, and 1 set of implant treats, say, about 1.5 to 2 centimeters. So even 1 set of implant took good care of that prostate. And this is the final appearance of both the sides implant, which are at 3 and 9 o'clock. And you can see a very nice opening without traversing the bladder neck. So my friends, there are good results, sizable improvement in IPSS and QMAX. There is no incidence of any de novo erectile or erectile dysfunction. Continence is maintained, and the quality of life and recovery is very good. The complications are there. They are very, very trivial. And there is enough literature evidence, substantial literature evidence for last decade or so. Now there are studies coming with 7 years results. This is one study which I wanted to elaborate. This BPH6 component, and they looked at 6 component: LUTS, erectile function, ejaculatory function, incontinence, quality of recovery, and de novo complication. And mind well, the interesting observation was, as compared to TURP, only barring LUTS rest, all 5 components, UROLIFT group patients did better than TURP. And that's why it has got found its place in AUA guidelines as an option. It has also got a place in the USI guideline. I'm happy and honored to have Dr. Sabnis sir here. Together we formulated this guideline. At that time, UROLIFT was not there, but still we could have them as an option. So my friends, the advantages is no catheter, can be done in local anesthesia. There is no hospitalization. You can walk in and walk out. No incontinence, ejaculation, erectile function is well preserved. Quality of recovery is excellent. However, there are few concerns, as Dr. Maheshwari pointed out last time. The long-term data is still not validated. The improvement is suboptimal, and the retreatment rate is quite high, maybe 13.6 to me, maybe 20% for him. But if you look at TURP, if we consider 5 years down the line, regrowth rate 5%, 4% stricture rate, 4% bladder neck contracture, even then it comes to around 13%. So it's the way you look. The problem in India is the cost. It's a huge constraint. Having said that, I would like all of you to take home this message that it is the most physiological way to treat patients, and it is not a substitute of HOLEPS or TURP. Mind that very well. And that's why careful selection of patient is of utmost importance to give a very good result. And who are the ideal candidates? When you go back home, you see these kind of patients who are relatively young, sexually active. It can be offered to them as an alternative to non-compliant patients in very high-risk patients, or there are patients who are not willing to undergo surgery because of the side effects and complications. These are the candidates. If you see in your OPD, you should have in the back of your mind UROLIFT as an option. Thank you so much for patient listening. I'm ahead of time. Dr. Kalna, thank you so much for this opportunity again.